Hello, my name is Ann Jay from the Georgetown University Hospital, and it is my pleasure to be moderating this session with one of my prior attendings, Dr. Larissa Villeneuve from the Children's Hospital of Pennsylvania. Welcome to our session, Pediatric and Systemic Diseases. Our first lecture will be given by Dr. Karen Moeller, who is an assistant professor of radiology at the University of Louisville Department of Radiology and the director of neuroradiology at Norton Children's Hospital there. Her topic for today is branchial apparatus anomalies.
Good afternoon. I'd like to thank Alana and the organizing committee for the invitation to participate in our first virtual meeting. During this session, we're going to talk about the branchial apparatus. We will review the embryology and then look at some anomalies that you may encounter in your practice. The branchial apparatus starts as a system of protrusions or arches that appear on the surface of the embryo at the 4th gestational week between the developing head and chest. 6 paired arches form along the inferior lateral aspect of the stomodeum or developing mouth. The 5th arch eventually regresses and the 4th and 6th arches fuse with each other. They're called branchial because they resemble branchia or gills in a fish, and it's proposed in humans that they be called pharyngeal, and both terms are correct, but really branchial continues to be used more often. We can take a coronal section through these arches and lay it out, looking at it from the front, so we're staring at the back wall of the developing pharynx. These mesodermal arches are lined by endoderm internally and ectoderm externally. The folds in between the arches are called clefts or grooves on the outside and pouches on the inside. So there's 4 paired pouches and clefts, and the first cleft and pouch will be just inferior to the first arch, and so on down the line. Now we can focus on one side of the developing neck, knowing the same thing is happening on the opposite side. Shortly after the 4th week, the second arch will start to proliferate and grow inferiorly towards another proliferation called the epicardial ridge. And that will cover up not only the second cleft, but the 3rd and 4th cleft, and completely obliterate them except for an ectodermal lined cavity called the cervical sinus of His, or just cervical sinus. And eventually that too will disappear, leaving us with the smooth outer surface of the neck if development proceeds normally. The first cleft goes on to form the external auditory canal, and together with the pouch, the tympanic membrane. Except for the skin, all the other clefts will completely regress in a normal situation. The auricle develops around the first branchial cleft, but it's actually derived from mesoderm in the 1st and 2nd arch. And it's difficult to make out the parts of the auricle on our cross-sectional image, but it can be helpful to be familiar with the parts when we're reading the otolaryngologist's requests and operating reports. We have the outer helix, the more anterior antihelix, the protrusion anteriorly, the tragus, the depression, the concha or concha bowl, and the lobe or lobule. The first pouch, together with the first cleft, again will form the tympanic membrane. It also forms the tympanic cavity mucosa and the eustachian tube. The second pouch will form the tonsillar fossa, and with help from adjacent mesoderm, the palatine tonsils. The 3rd pouch gives rise to the inferior parathyroid glands, thymus, and part of the piriform sinus. And the 4th pouch gives rise to superior parathyroid glands, the apex of the piriform sinus, and the ultimobrachial body, which is just the embryologic term for parafollicular cells or C cells in the thyroid gland. Notice that the inferior parathyroid glands start superior to the superior parathyroid glands. These will descend with the thymus, and they have a longer migration course, which explains why they're more likely to be ectopically located. We can also look at the arches that are composed of mesoderm and neural crest. Each arch has a nerve, or more specifically a cranial nerve, an artery, and a cartilage. The first arch, or mandibular arch, will give us the 5th cranial nerve and all of the muscles that innervates. Meckel's cartilage gives rise to mandible, malleus, and incus, and other bones in the lower face are also derived from the first arch, and the maxillary artery and external carotid artery are believed to be remnants of that first arch. The second arch, or hyoid arch, gives us the 7th cranial nerve and all of the muscles that innervates, and Reichardt's cartilage forms the stapes, the styloid process, stylohyoid ligament, and the superior hyoid bone. We also have, from the second arch, the stapedial artery, which we know in most patients will regress in fetal life. The third arch gives rise to the 9th cranial nerve, The stylopharyngeus muscle is the only pharyngeal muscle innervated by the ninth cranial nerve, the inferior hyoid bone, and the superior common carotid artery and inferior internal carotid artery. The fourth and sixth arches start to get interesting because they're fused with each other. Both are contributing to the 10th cranial nerve, but also we get asymmetry between right and left. So the fourth arch gives us a superior laryngeal branch of cranial nerve 10, some pharyngeal and laryngeal muscles, laryngeal cartilage, especially the thyroid cartilage, the aortic arch on the left, and the subclavian artery on the right. And then the sixth arch forms a recurrent laryngeal branch of cranial nerve 10 that recurs around the subclavian artery on the right and the aortic arch on the left. Laryngeal muscles, the lower laryngeal cartilages, pulmonary artery, and ductus arteriosus, which we know completely regresses on the right and closes shortly after birth on the left. An anomaly occurs if any of those embryologic structures, a pouch, cleft, or cervical sinus, completely fail to regress or obliterate. And we can have a closed system like a cyst, a sinus tract, which has one opening either externally to the skin or internally to the pharynx, or a fistula that connects two epithelialized surfaces. That's the general definition of a fistula, but in the setting of branchioapparatus anomaly, a purist would say that it should connect a cleft with a pouch, but that would be very rare. First, branchial cleft anomalies occur in those embryologically defined locations around the auricle, parotid gland, and mandible. They can be cysts, sinus, or fistula, and the sinus tract has a predilection to open near the bony and cartilaginous portion of the external auditory canal. Here's a 14-year-old boy who presented with recurrent swelling behind his ear. This was drained 3 times by general surgery before he came into the care of an otolaryngologist. On the CT 3D rendered image, you can see the focal swelling. It's skin covered, close to the lobule of the auricle. And on the sagittal post-contrast image, we see a well-circumscribed cyst with surrounding increased attenuation consistent with infection, which is what he had clinically. At axial image, we can see it's superficial to the superficial portion of the parotid gland, posterior to the auricle. And on the coronal image, we could appreciate the small sinus tract that extended from the cyst to the junction of the bony and cartilaginous EAC. Here's a 15-month-old girl who had drainage from a dimple in her skin in her inferior lateral face. And on the sagittal post-contrast CT, you can appreciate this big, irregular, elongated collection extending from the skin surface to the EAC. It went through the parotid gland, and this one connected to the cartilaginous external auditory canal. At pathology, there was a cyst and a tract, and we're calling it a fistula because it's connecting skin to EAC, but it's certainly not connecting a cleft with a pouch. It's all involving the cleft in this case. Here's a 2-year-old boy who had a sinus dimple in front of his ear. It was draining off and on for the entire 2 years of his life. On the CT with contrast, you can see the sinus tract and the subcutaneous fat, the small depression in the skin. It had rim enhancement, and this one ended at the concha bowl. And here in a 3-year-old girl, we had another sinus tract that went from the skin surface, and this one ended at the region of the tragus. The second branchial cleft anomaly is reportedly the most common, and these can be cyst, sinus, or rarely fistula. And they can arise anywhere along that embryologically defined tract from the tonsillar fossa to the anterior inferior neck. And the easiest way to remember Bailey type 1 through 4 for the subtypes is we go from superficial to deep. So 1 is just beneath the platysma, 2 is the most common between the sternocleidomastoid muscle and submandibular gland, 3 is next to the carotid bifurcation, and 4 is deep near the parapharyngeal face or tonsillar fossa. These occur in young patients, so if you see a cystic mass in an older patient, it's important to consider the possibility of nodal metastases. Here's a 12-year-old boy with a classic second brachial cleft cyst. You see this unilocular cyst with a thin wall, anterior to the sternocleidomastoid muscle, posterior to the submandibular gland, which was one slice inferior to this, and lateral to the carotid space. At pathology, in the same case, there was stratified squamous epithelium, defining it as a cleft anomaly, whereas a pouch anomaly would theoretically have columnar epithelium. But what's important to remember is that the pathologist cannot tell us what subtype 1 through 4 branchial cleft cyst it is. The histology is the same for all of them, and it's really up to us as radiologists or the surgeons to tell them the subtype based on the location. And here from the literature is the Bailey type 4 second brachial cleft cyst. It's deep, it's next to the parapharyngeal face and space and tonsillar fossa, but it looks like a cyst on T2 and T1 weighted images. Often these patients will come to attention because of infection, like in this case, they'll have swelling, fever, and focal swelling where the cyst is. Here we can see the cyst surrounded by edema and inflammation consistent with cellulitis. So this is the most common location for second brachial cleft cyst, and the second brachial cleft cyst is the most common subtype, but more often what we're going to see in this location is lymph nodes. And we'll see this every day in pediatrics because they have a lot of reactive lymph nodes. Here in a healthy 11-month-old boy on axial T2 weighted image, we see these level 2 nodes, 2 of which are positioned perfectly between the submandibular gland and sternocleidomastoid muscle. Here in a 10-year-old boy, we have low density nodes. They don't quite look like a cyst. They're more irregular with irregular wall. It's bilateral. And clearly this patient also has an abnormal, ugly looking mass involving the epiglottis and left area epiglottic fold and another node lower down. And this unfortunately was a supraglottic nut carcinoma. This is a rare aggressive subtype of squamous cell carcinoma. It occurs in younger patients with a median age of 17. It's genetically defined and it can occur anywhere, including the head and neck. Here's a 13-year-old girl with a solid mass between the submandibular gland and sternocleidomastoid muscle. Lower down, there was a mass in the left lobe of the thyroid gland and other lymph nodes. And this is papillary thyroid carcinoma with metastatic lymphadenopathy. So this doesn't look like a cyst. It's solid, it's hyperdense. But we know that differentiated thyroid carcinoma can have cystic lymphadenopathy that could easily occur in this location. Moving on to the third branchial cleft anomaly, we're getting into the rare of the rare. These can be cyst, sinus, or fistula, and compared to the second brachial cleft cyst, they're more likely to be posteriorly located, especially when we get higher up in the neck. Here's a classic third brachial cleft cyst. It's posterior to the carotid space, completely deep to the sternocleidomastoid muscle, and looks like a simple cyst. Here's an 8-month-old girl who we thought was going to have a third branchial cleft sinus tract. She had a draining sinus in the anterior inferior neck, and here we are down at the level of the thyroid gland. We followed it up, and it looks spherical on axial images and sort of tram track on sagittal and coronal sequences. But as we got higher up near the hyoid bone, the tract stayed in the anterior subcutaneous fat. It never went posterior, so we ended up calling it a second brachial cleft sinus. And if you put these tracks side by side, you can see that as we get higher, theoretically, the third branchial cleft sinus at the level of the carotid bifurcation should be more posteriorly located. Let's talk about the third branchial pouch. It gives us the thymus and inferior parathyroid glands. The thymus will descend from the superior neck to the mediastinum between 6 and 9 weeks gestation and sort of carry the inferior parathyroid glands along with it and drop them off along the posterior inferior thyroid gland. It's worthwhile to talk about the normal thymus because we do see it a lot in pediatrics almost every day. It resides in the anterior mediastinum and inferior neck. It proliferates after birth, and relative to the chest, it has a maximum appearance during infancy, but the absolute volume is actually maximum in adolescence, and then it involutes in adulthood. It's important for the maturation of the immune system, especially the T cells, and it also produces T cells. So here in a 1-month-old girl on a sagittal T2 weighted image, we see the normal thymus in the inferior neck and mediastinum. It can get a little tricky on axial images because it looks nodular, simulating lymph nodes, and it's very typical for the lobes of the thymus to be asymmetric with each other. It's behind the strat muscles and also posterior to the sternocleidomastoid muscle. And the easiest way to sort it out is to look at your sagittal images because you can clearly see that this is thymus, contiguous with the rest of the thymus in the mediastinum. And here in a 12-year-old girl, we're looking at the thymus when it's maximum in volume. It's normal for the thymus to have outer convex margins up to the age of 20. Often the lobes are asymmetric and they can have variable fusion with each other. In this case, they're not fused anteriorly, but they are fused posteriorly. And notice how in this case, the thymus is thicker in the inferior neck compared to the mediastinum. An anomaly of the third brachial pouch includes ectopic thymus, cervical thymic cyst, or ectopic inferior parathyroid glands, which becomes important in adults when we're looking for adenomas. An ectopic thymus can occur anywhere from the submandibular region to the mediastinum along that duct. An ectopic thymus really is the preferred term since normal thymus resides in the neck. Cervical thymus is a little misleading. It requires no treatment and it will regress with age like the rest of the thymus. So here's an 8-month-old boy with an axial T1 weighted image with solid mass posterior to the submandibular gland. It looks homogeneous. But the key to this diagnosis is comparing the mass to the rest of the thymus. And here you can appreciate that it's homogeneous and completely isointense to the rest of the thymus on T2 and post-contrast T1 weighted images. Cervical thymic cyst occurs if the thymic remnant interacts with surrounding mesoderm or neural crest to produce a cyst. And it's difficult to tell this cyst from other congenital cysts on imaging preoperatively. One clue is that they tend to be vertically extensive, but it's really up to the pathologist. They'll see the Hassel corpuscles or normal thymic tissue in the wall of the cyst. It can occur anywhere along the thymopharyngeal duct. And here in a young patient, we're at the level of the hyoid bone. We see this big unilocular cyst. It continued all the way down into the mediastinum, and here it is at surgery, very elongated and vertically extensive. And here in a younger patient, he presented with left neck swelling. We see this big unilocular cyst with displacement of the airway. It had a fluid level. And notice that it's completely separate from the normal thymus below it. We'll finish off with the fourth branchial apparatus. The most common anomaly is a sinus tract that emanates from the piriform sinus. And the traditional teaching is that if the sinus tract comes from the apex, it's a fourth pouch anomaly. If it comes from the lateral piriform sinus, it's a third pouch anomaly. But this paper out of Toronto sick kids argued that all of these are more related to the thymopharyngeal duct and therefore third pouch anomaly. Regardless of the embryology, the treatment and diagnosis is the same. These patients present with recurrent infection, often involving the left thyroid lobe, and the predilection for the left side is thought to be related to that embryologic asymmetry we see with the lower arches. Here's a 13-year-old boy who presented with fever and swelling. There was an abscess in the left lobe of the thyroid gland, normal right thyroid, and it looked irregular on coronal images. At barium swallow on the delayed image, we saw abnormal extravasation of contrast from the piriform apex into the inferior neck. So the barium swallow can be helpful, but it only has a sensitivity of 50%. So the current recommendation for these patients is to go directly to pharyngoscopy, which more definitively will define the sinus tract. It's important to resect the entire sinus tract, otherwise the infection will keep recurring. So in summary, we looked at the branchial apparatus, which is a fascinating system of arches, clefts, and pouches that form the structures of the head and neck. Cyst, sinus, and fistula can form along these embryologically defined tracts, and the location provides a clue to the origin of the anomaly. You will see these, but they're very rare, so it's important to consider the differential diagnosis. And if a patient has a left thyroid infection, the study of choice to work it up is a pharyngoscopy looking for that sinus tract. I'd like to thank you, and I hope you enjoyed the rest of the meeting.
Our next lecture will be given by Dr. Timothy Booth, who is the Chief of Pediatric Radiology and Professor of Radiology and Otolaryngology at the University of Texas Southwestern Children's Health System in Dallas, Texas. His topic for today is thyroglossal duct remnant anomalies.
Thank you to the program chair and committee for inviting me to talk to you today about thyroglossal duct remnant anomalies and mimics. I have no disclosures. Our objectives are to know the pertinent embryology associated with cystic lesions within the anterior neck, be able to identify the typical imaging features of a thyroglossal duct remnant, and stress its association with the hyoid bone, review clinical and imaging differential diagnoses. A brief review of the embryology. The thyroid gland is the first endocrine organ to develop within the 4th week. It begins at the foramen cecum and descends within an epithelial-lined channel inferiorly. It descends ventral to the hyoid and laryngeal cartilages, posterior to the hyoid in 30% and may be duplicated inferiorly, explaining the paramidline location of more inferiorly located thyroglossal duct cysts. It achieves its final position at the 7th week inferior to the cricoid. These are diagrams demonstrating the origin of the thyroglossal duct from the primitive pharynx and extending inferiorly with a thyroid gland at the tip. The course of the descent extends from the foramen cecum, which is located at the junction of the anterior 2/3 and posterior 1/3 of the tongue, extends inferiorly over the hyoid bone, laryngeal cartilage, and achieves its final position inferior to the cricoid. Normal variants include the pyramidal lobe, which is just a superior extension of thyroid tissue from the isthmus. Here we see on an I-123 uptake scan, uptake within a normal pyramidal lobe of the thyroid gland. We can also see this on CT. There is a triangular extension of normal thyroid gland superiorly from the thyroid isthmus. The other normal variant is small asymptomatic cyst within the posterior aspect of the tongue at the foramen cecum, likely relating to small thyroglossal duct cysts. Most of these are asymptomatic and only need a referral to the otolaryngologist. Here's a 1-year-old with seizures, an incidental small thyroglossal duct cyst within the posterior aspect of the tongue. Thyroglossal duct cysts are the most common anterior non-odontogenic cyst in the neck. It can occur anywhere along the path of the thyroglossal duct. 65% are infrahyoid. Suprahyoid lesions tend to be midline, and infrahyoid cysts tend to be paramidline. We image due to a clinically suspected mass. We usually use ultrasound first. CT and MRI is helpful if there's an atypical location. Concerning features such as solid component, abnormal vascularity, atypical location, or appearance are present. Surgery includes resection of the cyst, tract, and anterior body of the hyoid, the so-called cyst trunk procedure. Resecting the anterior body of the hyoid is key in that it prevents recurrence. Histopathologically, we can see pseudostratified ciliated columnar epithelium superior to the thyroid gland. At the level of the foramen cecum, we tend to see squamous epithelium. We can also see thyroid tissue, as demonstrated here by thyroid follicles. We can also see salivary and hyoid tissue. These cysts develop due to repeated infection and secretions within the thyroglossal duct. Ultrasound is used for a typical presentation. It's usually a cystic midline mass that's hypoechoic, although can have increased echoes within it. No Doppler flow through sound transmission is usually demonstrated. It's within the strap musculature. It's usually related to the hyoid bone, and we always want to document normal thyroid. Concerning features include a solid component or increased vascularity. Here's an 18-month-old with an infrahyoid midline neck mass. We see a unilocular, hypoechoic mass with through sound transmission and no Doppler flow. This child did not require additional imaging, and this was resected. This is a suprahyoid midline mass, which demonstrates increased echoes within the mass due to hemorrhage or proteinaceous secretions. There is no Doppler flow on the Doppler examination, and again, this child was sent directly to surgery. Computed tomography can be used certainly for atypical presentations. Thyroglossal duct cysts are uncommon in the very young. If there's no infection, we look for smooth unilocular margins, hypoattenuating, and we also always want to look for that solid component, although quite rare in children. This is a 1-month-old with an anterior neck mass. We see a large submental mass on the axial images, but the sagittal images really show us the association with the hyoid bone and the extension inferiorly into the upper neck. This is a 2-year-old with an anterior neck mass. We see again the association with the hyoid bone. There's the hyoid bone, or partial volume averaging of the hyoid bone with a surrounding cyst, and we can see the hyoid bone on the next image superior. When there's infection, there certainly can be proteinaceous material within, and the lesion can be of increased density, irregular margins, as well as septations. Here we see that there is a thyroglossal duct cyst, again associated with the hyoid bone, extending up into the floor of the mouth, and then with a large amount of associated inflammatory changes within the more anterior floor of the mouth. This child also had a direct involvement of the hyoid bone with a small extension within the anterior body. On MRI, this is a 14-year-old with a submental mass, and again we see that there's a thick rimmed mass within the submental region. There's rind-like enhancement with septations, but really no restricted diffusion, maybe a bit of restricted diffusion anteriorly, and this pathologically ended up being an infected thyroglossal duct cyst. MRI again tends to demonstrate a unilocular mass, can extend from the tongue to the thyroid, usually within or posterior to the strap muscles. Signal intensity again is related to content, and there's usually no or peripheral enhancement with the absence of infection, and no restricted diffusion. This is a 1-year-old with a midline neck mass. We see nicely the large inferior component, but again the association with the hyoid bone and the extension up into the posterior aspect of the tongue makes this diagnostic of a thyroglossal duct cyst. There's no restricted diffusion on the diffusion weighted images. This is a 4-year-old with a neck mass. Again, this is a fairly well-defined unilocular mass within the strap musculature, just superior to the level of the thyroid gland. But the sagittal T2 weighted images show us nicely that this lesion extends posterior to the hyoid bone, and this was pathologically confirmed to represent a thyroglossal duct cyst. Now, they all don't play by the rules. This is a child with a cystic lesion, dark on T1, bright on T2, no restricted diffusion, but it's anterior to the strap musculature. The fact that it doesn't restrict indicates to me that it's likely not a dermoid, and this was called a thyroglossal duct cyst and turned out to be that. Now, we can see an association with thyroid cancer in approximately 1%. It arises within the thyroglossal duct remnant, likely within residual thyroid tissue, but these tend to occur in much older individuals, and usually greater than 40 years of age. If we see calcifications on a CT or ultrasound, that's highly indicative of tumor. This is a child, a 9-year-old with an anterior neck mass, was sent in for evaluate for thyroglossal duct cyst. We see that the ultrasound demonstrated a large amount of peripheral flow on the Doppler exam. Ended up getting an MRI, which we see this thick rim of tissue with central cystic component or necrotic component. Here's a necrotic component on the post-gadolinium images with peripheral enhancement. The central component did restrict, and this was thought to either represent an infected thyroglossal duct cyst or possibly a tumor. This ended up getting resected and ended up being papillary thyroid carcinoma, likely arising within a thyroglossal duct remnant. Evaluation of midline neck masses, we always want to evaluate for the thyroid gland. Thyroid tissue may be within the cyst or just ectopic. So here's a child with a mass within the strap musculature. It's slightly bright to muscle on the T1 weighted images. There's no thyroid gland within the thyroid bed on the more inferiorly located T1 weighted image. And here, after contrast administration, we see that there's some mild enhancement. And this was thought to represent ectopic thyroid, possibly within a thyroglossal duct remnant. The thyroid technetium scan demonstrated uptake, and this turned out to be pathologically ectopic thyroid tissue. And this child went on to thyroid supplemental medication. Congenital abnormalities include, we mostly image for congenital hypothyroidism, It's obtained in a neonatal screening in Texas and I believe around the country. These are documented as either primary or secondary, and really our imaging job is to document the presence or absence of the thyroid gland, but also to scan the entire midline neck to see if there's residual thyroid tissue along the expected region of the thyroglossal duct. This is an ultrasound which demonstrated no thyroid gland within the thyroid bed and no additional thyroid tissue elsewhere. Now, they can be ectopic, and usually within the lingual region, these children may be euthyroid or, more commonly, hypothyroid. This is an 11-year-old with dysphagia and hypothyroidism. Here we see on the CT that there is a mass within the posterior aspect of the tongue which demonstrates intense enhancement. If we did a non-contrast study, this would be slightly hyperdense, as you would expect normal thyroid gland. This is a lingual thyroid. This is another child, a 2-month-old with hypothyroidism that underwent a 99M technetium thyroid scan, which shows the only viable thyroid within the posterior aspect of the tongue. Now, they can occur anywhere along the duct, and internal flow can be quite variable on Doppler, depending on its function. Here's a 15-year-old with hypothyroidism and mass anterior to the thyroid. This is, again, a well-defined mass lesion with internal echoes and flow demonstrated on Doppler. This was thought to represent ectopic thyroid tissue. Dermoid could also look like this, but again would not have internal flow. We did a thyroid scan, which demonstrates uptake within the lesion located anterior to the hyoid bone. This is an example of these lesions can be multiple. So this is actually a lingual thyroid gland here, but as we extend inferiorly along the expected course of the thyroglossal duct, we see additional ectopic thyroid tissue inferior to the hyoid bone as well. So now we'll discuss some mimics based on location. So when I think of tongue lesions, I think foregut duplication cyst, especially if it's located anteriorly. These children tend to be present in the newborn period with symptoms such as poor latching and bottle feeding due to the mass effect from the lesion. Again, these tend to be cystic and anteriorly located. Here's a T1 weighted image that shows an anterior lesion within the tongue that's hypointense on T1 weighted images, homogeneously hyperintense on T2 weighted images, and no enhancement on the post-gadolinium images, and this ended up being pathologically a foregut duplication cyst. This is a dermoid. They're typically midline within the floor of the mouth. They're usually contained by the mylohyoid muscle inferiorly. This is a submental lesion here, floor of the mouth. There's the mylohyoid muscle draping inferiorly under the lesion, and here we see on the coronal images the lesion contained by the mylohyoid muscle. Sometimes negative Hounsfield units can be helpful in these lesions to make the diagnosis. This is a 14-year-old with an upper neck mass. MRI is nice in these cases in the fact that it again demonstrates the cystic characteristics of the mass, contained a bit off midline but still contained by the mylohyoid muscle. And diffusion-weighted images can be quite helpful in the fact that there's usually increased or restricted diffusion associated with these lesions, and this had the more fat bubble appearance of restricted diffusion on the diffusion-weighted images. Lymphatic malformations can also occur within the tongue. They tend to be infiltrative, multilocular, and we always want to look for fluid levels. They can have a venous component commonly within the tongue. Here's a extensive lesion involving nearly the entire tongue with multiple fluid levels, bright on T2 weighted images, and demonstrating the characteristic septal and peripheral enhance on these post-gadolinium T1 fat saturation images. Ranulas can also occur in the floor of the mouth and are usually associated with the sublingual gland, and they begin within the sublingual space. This is a typical ranula, again involving the sublingual space associated with the sublingual gland and extending posteriorly, but still confined by the mylohyoid muscle on these coronal T2 weighted images. Now, when a plunges, the predominant cystic component is located posteriorly, but we always want to search for this extension past the mylohyoid muscle into the sublingual space. And usually the more posterior component is the more prominent, so we want to look very carefully for this sublingual extension. Follicular cysts can occur within the more posterior aspect of the tongue. These are mucus retention cysts, but can occur anywhere. Here's, again, would be in the differential of a thyroglossal duct cyst, but this is much more posterior than you would expect, and there's actually mass effect on the epiglottis. It's homogeneously bright on T2 weighted images and demonstrates no enhancement after gadolinium administration. Mimics within the anterior neck. Again, dermoids enter the differential diagnosis. These tend to be hyperechoic on ultrasound, but uniformly so. No flow on Doppler. And on CT can be low density due to their fat content, but not always. They're usually subcutaneous. Here's a lesion, again, homogeneously increased echogenicity on ultrasound within the anterior inferior neck that had no Doppler flow and was diagnosed as a dermoid cyst. This is a child that ended up getting an MRI first and ended up having this typical soap bubble sort of appearance on MRI, which is diagnostic for a dermoid, but this is actually within the sort of adjacent paraglottic musculature. This child ended up getting a CT for another reason, and we see that there were actually negative Houndfield units associated with this lesion, so a diagnosis of dermoid was made. This is a 3-year-old with a suprasternal lump, and again, this homogeneous increased echogenicity, no flow on Doppler. The diagnosis of dermoid was made. This is an MRI example of a dermoid. This is a 1-year-old with a lump for a month. It's more suprasternal, but certainly at the level of the thyroid gland. We see it's homogeneously hyperintense on T2 weighted images, and it's homogeneously restricted on the diffusion weighted images, and that cinches the diagnosis of dermoid. Lymphatic malformations can also occur in the anterior neck. They tend to be, again, multilocular, echogenic septae, and anterior to the strap musculature on ultrasound. Here's a lesion within the anterior neck at the level of the hyoid bone. We see that there are multiple echogenic septations. It's multilocular, it's hypoechoic. The diagnosis of lymphatic malformation is fairly straightforward. MRI and CT characteristics include similar findings, multilocular, fluid levels, and again, usually doesn't arise within musculature. Here's a CT that demonstrates multiple cysts, so it's multilocular, anterior lateral within the neck. The MRI on the same patient demonstrates homogeneous increased intensity, and they're enhancing septations on the post-gadolinium fat sat images. Internal or external laryngoceles or saccular cysts can also present very similar to thyroglossal duct cysts. It's a congenital saccule of the laryngeal ventricle. It usually penetrates the thyrohyoid membrane, and that results in the external component. This can also occur with thyroglossal duct cysts, so these need to be confirmed on direct laryngoscopy. Fluid and or air may be present within the cyst. And here we see a predominant external component here, but the internal component extends through the thyrohyoid membrane in this child that actually did not have communication with airway and pathologically was proven to be a saccular cyst. Now, thymopharyngeal duct remnants can also occur within this region. The thymus descends at a similar time as the thyroid gland, and these are often called third or fourth branchial anomalies. It extends from the piriform sinus inferiorly, begins retropharyngeal, and then extends anteriorly as one extends inferiorly within the neck. There are two distinct presentations depending on age. Neonate or infant presents with a large cyst, retropharyngeal superiorly, and then extends into the more anterior mediastinum. They commonly infected with fluid levels, and air may be present but is rare. Treatment includes drainage and resection, and again, drainage of the entire duct extending to the piriform sinus. This is an 18-day-old with a large mass. We see a fluid level on ultrasound, and we see the extent of the mass, which is predominantly retropharyngeal superiorly, but extends anteriorly in a paraglottic fashion. The thymopharyngeal duct sinus presents in children, so 6 to 8 years old. They have recurrent neck abscesses associated with suppurative thyroiditis. Imaging, we want to see inflammation along the course of the thymopharyngeal duct. Air is uncommon but can be present, and fluoroscopy usually is not needed. These kids tend to be referred directly to laryngoscopy to evaluate for a piriform sinus communication. This is a 4-year-old with left neck swelling. We see that there's a suppurative thyroiditis on the left, but as we extend superiorly, we see a paraglottic inflammatory process extending all the way up to the piriform sinus, and during direct laryngoscopy, a fistula was seen within the apex of the piriform sinus. These can also be cauterized or resected. It kind of depends on the preference of your otolaryngologist. Ectymic thymus can occur anywhere along the thymopharyngeal duct. It's commonly incidental. It looks like thymus. There's minimal mass effect associated. We see a typical starry sky appearance on ultrasound with these multiple echogenic foci. On MRI, we're looking for its isointense signal to normal thymus. And MRI shows this ectopic thymus within the more lateral neck, which again is isointense to normal thymus within the anterior mediastinum. And lastly, we'll touch on branchial cysts. Usually second branchial anomalies enter in the differential diagnosis here. These may be external or internal. They can be complete fistulas and can be isolated cysts. The important thing is the location. It has to be along the expected course of the second branchial fistula, which extends from the palatine fossa or tonsillar fossa through the internal and external carotid, and then courses inferiorly along the anterior margin of the sternocleidomastoid mastoid muscle. So this is a CT fistulogram that we did. We used the silogram needle to access the tract. We used airway protection with an inflated cuff, and we see that there's contrast extending through the fistulous tract superiorly between the submandibular gland and sternocleidomastoid mastoid muscle, and then we see it project medially and dump out into the region of the tonsillar fossa. They're usually unilacular between the submandibular gland and sternocleidomastoid mastoid muscle. This is the Bailey type 2 second branchial cleft cyst. Their fluid density, signal intensity, and then can be infected and have surrounding inflammation. Look for that beak extension between the internal and external carotid. I think it's very helpful. And they don't have an extension to the hyoid bone, and that's a nice differential point as well. Cystic nodes are quite rare, although can be included in the differential diagnosis, but not common in children. Here's a 17-year-old with a left neck mass, which shows a large cyst between the submandibular gland and the sternocleidomastoid, and you get an idea that it's almost extending through the junction between, or the space between, the external and internal carotid artery. This is kind of just a case in point as far as stressing location. This is a 9-month-old with a submandibular gland region mass that was called a second branchial cleft cyst, but it just doesn't make sense. So again, second branchial cleft cyst should be located between the submandibular gland and the sternocleidomastoid muscle. This is actually medial to the submandibular gland. There's a little bit of soft tissue within it, and then we see on the DWI that there's a little bit of restricted diffusion, and this actually ended up being a dermoid. But again, doesn't make sense for a branchial cleft cyst because it doesn't follow the normal course. So, in summary, thyroglossal duct cyst is the most common congenital neck mass. Its relationship with the hyoid is critical in the diagnosis. We always want to include evaluation of the thyroid gland itself. Dermoid cysts are commonly encountered and may have a typical imaging appearance, as can lymphatic malformations. Location, age, presentation are extremely helpful in limiting the differential diagnosis in these cases. Thank you very much for your time.
Following Dr. Booth will be Dr. Deborah Schatzkes, who needs no introduction. She's a professor of radiology and otolaryngology at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. She is a chief of head and neck radiology at Lenox Hill Hospital and the New York Head and Neck Institute. Her topic for today is vascular malformations, distinguishing clinical and imaging features in the head and neck.
Hi, I'm Debbie Schatzkes. I'm from Lenox Hill Hospital in New York, and I'm going to talk to you about vascular malformations and specifically the way that we can distinguish, based on clinical and imaging features, some of the more common lesions that we'll see in the head and neck. So in preparation for this talk, there was a case I was looking for, and I remember that I had tweeted it. So I looked at my Twitter posts, and after doing so for a little while, realized that I had really strong feelings about this topic, and they were definitely coming out in my Twitter posts. I noticed, a lot of exclamation points, a lot of capitalized words, a lot of statements that struck me kind of in retrospect as slightly obnoxious. I kind of realized that there were people I'd never met in person who seemed to realize that I had these very strong feelings on the topic. Matt, Lorenzo, Christine, and all of the people that I expressed these strong feelings to in perhaps a slightly obnoxious manner, I do apologize to everyone. Okay, but the fact is that there is a problem, and it has to do with the words that exist around vascular malformations. So a little history. In 1982, John Mulligan and colleagues from Harvard published what was the seminal work on the biologic basis of these vascular lesions. And about 10 years later, the International Society for the Study of Vascular Anomalies, or ISFA, was formed to standardize the classification, the nomenclature, to have an area where all the different disciplines who were involved in the treatment of these lesions and the research involved to come together. But as recently as 2013, John Mulligan wrote in his most recent edition of his textbook on vascular anomalies that nomenclature has been the major obstacle to our understanding and management of vascular anomalies. So, over 30 years had passed and still problems with classification and nomenclature. And really, the overuse or in the incorrect use of the terms hemangioma and angioma to describe any vascular lesion has really been a lot of the problem. So, for example, these lesions are all called hemangioma. We see the enhancing orbital mass called a cavernous hemangioma. The middle image is an enhancing lesion along the petrous ridge, which gets called a facial nerve hemangioma. And then finally, the image on your right showing you an ossifying hemangioma. But, as the quotation marks imply, these are not correct. And Borat will actually help us out by giving us a hint that these are all, in fact, venous malformations, and we'll visit these lesions in a few minutes. So why does this matter? It matters because the inaccuracy that we see in our usage in everyday practice is also present in the literature. Dr. Hassanen, also from Harvard, did a very interesting project. He did a PubMed search for the word hemangioma appearing either in title or abstract, and he found that it was used incorrectly 70% of the time. So that means that our literature is full of incorrect usage. And not only that, but when these lesions are mislabeled, inappropriate treatment was rendered 20% of the time. So these words really do matter. Using correct terminology, classifying these lesions correctly really does matter. All right, so let's talk about Dr. Mulligan's work. So this may be the most important slide in this whole talk because it really condenses the biologic basis of our understanding of these lesions. And there are two types. There are vascular tumors and the infantile hemangioma, that common lesion that you will see not infrequently in children. They are examples of vascular benign neoplasms, and these are true neoplasms. They grow by endothelial hyperplasia. On the other hand, vascular malformations are not tumors. They have a quiescent endothelium. What they are defects of vascular morphogenesis. So the term malformation, and Dr. Mulliken actually points this out, means badly formed vessels. And that's the best way to think about these lesions. They're not tumors. They are just vessels that grew incorrectly in utero, and they are static. They are not going to grow like tumors. And the immunohistochemical marker GLUT1 can accurately distinguish between these categories. So here is the ISFA classification for vascular anomalies. It is a recent revision from May 2018. And you can find this on the web address that's listed on the bottom, isfa.org/classification. And I would really strongly recommend taking a look at this. This is the landing page, but each one of the links below are active, and they will give you all sorts of great information about these lesions. It's very easy to navigate, worth taking a look. So you'll see that this is really based on Dr. Mulliken's work. There are vascular tumors on the left, and hemangioma is by far the most common in this category, but there are other benign vascular tumors as well as locally aggressive or borderline lesions like hemangioendotheliomas, and then malignant vascular tumors such as, for example, angiosarcoma, all in the category of vascular tumors. On the other hand, vascular malformations is a much broader and more heterogeneous group of lesions, and they're named by their vessel of origin. So you can see under the simple column that there are capillary, lymphatic, venous, arteriovenous malformations, and arteriovenous fistulae. And then each one of those can be combined with others to create combined vascular malformations. And then there are other categories such as malformations of major named vessels and associated with other anomalies. And again, you can go to the isfa.org classification and click on these, and you will get a really nicely organized, detailed list. So this is my very simplified MRI-based differential algorithm, and this helps me tell the difference between 4 of the most common lesions that we see in the head and neck. And these are hemangiomas, AVMs, venous malformations, and lymphatic malformations, and we're going to talk about each of these for the remainder of the talk. And you can see how I've organized these as enhancing, CE, contrast enhancing, versus non-enhancing lesions, and lesions with moderate T2 hyperintensity versus lesions with very bright T2 signal intensity. So as we discuss these lesions, we'll discuss how they fit into each of these categories. All right, so let's first start with infantile hemangiomas. Again, these are extremely common, benign, vascular tumors of infancy, and these typically will occur on the skin, and you'll get this sort of raised red lesion that you see on the image on your right. Importantly, these are not present at birth, and this can be used as a distinguishing feature in cases that you may find the imaging unclear. They appear a few weeks to a couple of months after birth and have an initial phase of rapid growth called the proliferative phase, or phase 1. They will regress slowly, beginning in sort of toddlerhood, entering an involuting phase, or phase 2, and finally, the vast majority of these will completely regress spontaneously by late childhood, and that is then called the involuted phase, or phase 3. Now, as mentioned, they express GLUT1 because they are endothelial tumors. So let's look at the imaging, and it differs based on the phase. So we image these most commonly in phase 1 because that's when they're rapidly growing. So these are, again, hypercellular and hypervascular tumors, and because of that, they demonstrate both avid enhancement but only moderate T2 hyperintensity. So if we look at the images on the right, we can see this really avidly enhancing lobular mass. And on the lower image, we can see that it is giving us moderate T2 hyperintensity, quite a bit less than the signal in the vitreous or in the CSF. Notice also on those images that there are those serpiginous areas of vascular flow voids within this, representing the large vessels during these proliferative phases. So if we look at our chart, we can see that this lives in the upper left-hand corner. This is a contrast-enhancing lesion that demonstrates moderate T2 hyperintensity. Another phase 1 infantile hemangioma, and we can see that there is intermediate signal both on T1 and T2 weighted imaging. Notice again that the T2 signal is quite a bit less than the CSF. But take a look at both the internal flow voids as demonstrated on the right-hand image, but also look how large that superior ophthalmic vein is that's draining this very hypervascular tumor. And the appearance of large internal feeding and draining vessels is very characteristic of hemangiomas in the proliferative phase. Now, as they enter phase 2, the involuting phase, they will tend to decrease in volume, so they will become less bulky. They'll decrease in enhancement, and they will increase in their volume of these fatty interstices, as you can see on the two different patients' images. Finally, in phase 3, they will involute completely, but they will often leave a fatty mass that may demonstrate minimal contrast enhancement. So, this may be a problem cosmetically. You can see on the images above, the child still has relative fullness of that left cheek. And that's not just because of the residual fatty involuted hemangioma, but also because there's been some skeletal overgrowth related to the prolonged hypervascularity from the proliferative phase. So these can be addressed with cosmetic surgical procedures, and typically there will be little, if any, residua. An interesting syndrome in association with hemangiomas is FACE syndrome, and that's an acronym for posterior fossa, hemangioma, arterial, cardiac, and eye anomalies. So these patients typically will have facial hemangiomas that occur segmentally, and they're often going to be in the distribution of the branches of the trigeminal nerve or as a midline forehead lesion. The posterior fossa anomaly that's most commonly associated with FACE syndrome is cerebellar hypoplasia, as you can see on the image on the right. Arterial anomalies are very common, and in some cases there may be complete aplasia, and you can see on the upper image that the cavernous internal carotid artery is absent. And also there is a very large Meckel's cave on that side. Both of these have been reported in association with FACE syndrome. The lower image shows you another kind of fairly common vascular anomaly that we may see in these patients. This kind of corkscrewing of the ICA kind of just below the skull base is a very common appearance as well. All right, well, let's switch gears and go to vascular malformations and talk about the clinical features. So here we are now in the yellow portion of our ISFA classification. Again, we see how this is a much more heterogeneous group of lesions, again named after their vessel of origin, so capillary, lymphatic, venous, etc., as well as these combined variants, which can really give you very complex imaging features. What they do all have in common, though, is that they are present at birth. Remember, these are malformed vessels, and they grow in a linear fashion. So as the child grows, these will grow in concert, and they will never go away on their own. So if they require, if there is a functional or cosmetic reason that these need to be addressed, you can't just wait them out as you can often do in the setting of infantile hemangiomas. So these are GLUT1 negative, they're not neoplasms, and they can be broadly classified as high flow and low flow lesions, and pretty much anything with an A in it, meaning with an arterial component, is going to be a high flow lesion, whereas the rest of these will typically be low flow lesions. So let's start with the venous malformation, and these are really quite common. And once you know what they look like, you'll find these incidentally on imaging studies done for completely unrelated indications. So these are malformed venous channels, and they have very sluggish flow. So these are not cellular tumors, and they will typically give you very high T2 signal intensity. They don't have all that cellular content to give you a somewhat more solid appearance. They're kind of sacs of blood, and because the flow is sort of sluggish in them, they tend to enhance in a very patchy and non-uniform way that will often fill in if you image at a later time. So patchy progressive enhancement is really characteristic, as you can see on the upper image on your right-hand side. Now, because of that sluggish flow, it's common to get phleboliths within these lesions, and if you do see a phlebolith in an enhancing and T2 hyperintense lesion, most likely you're going to be dealing with a venous malformation. So in our chart, we're going to put this on the bottom left. This is a contrast enhancing lesion that typically demonstrates very, very bright T2 signal intensity. So again, phleboliths are extremely common and almost pathognomonic. So if we look at the image on the left, there is a lesion that's in the masseter muscle. We can see that there are two round calcifications. Those are phleboliths. And on the coronal T2 image on the right, we see phleboliths as areas of signal void, and these won't be linear vascular flow voids. They're going to be just typically round areas of signal void. Now, both of these lesions are in the masticator space, and that's a very common place to find venous malformations. And in particular, the masseter muscle is a really common place to find VMs. So we talked in our opening slides about the lesion that is commonly but incorrectly called the orbital cavernous hemangioma, and that is, in fact, an orbital venous malformation. So this is the most common cause of an orbital mass in an adult, and it typically will appear as a well-defined lesion. And on early post-contrast imaging, we're going to see, again, patchy contrast enhancement. But if we image a little bit later, perhaps you're doing a whole brain sequence in addition to your orbital imaging, take a look at that, because if that fills in, that is a really good sign that you're dealing with an orbital venous malformation. So again, going back to our initial slides, I showed you an example of a facial nerve hemangioma, and those are correctly called intraosseous venous malformations. They are just a form of the so-called ossifying hemangiomas. These typically occur at the level of the geniculate ganglion. We're going to see typically an expansile lesion, and it's going to have that sort of corduroy pattern with areas of sort of calcification within it. It's going to give you very bright contrast enhancement, and both on the post-contrast and the KISS image, you can see those little dots, those areas of signal void representing the internal bone spicules that are so common in this lesion. Another site is in the facial skeleton, and again, we can see an expansile lucent lesion with internal bony spicules. Again, those are going to be visible on the contrast-enhanced image, the middle image, as well as that T2 weighted image. This is a real T2 image as opposed to the KISS that I showed you previously, and you can see how bright these are. We see these, throughout the body, and likely this is what we're looking at when we see spinal hemangiomas as well. So let's take a moment to review the differences between hemangiomas and venous malformations, because that's probably the most commonly misconstrued diagnoses. So remember again that hemangiomas, as on the left-sided image, are hypercellular and hypervascular tumors. They're going to have large internal vessels during the proliferative phase, which is when we image them most commonly, and again, only moderate T2 hyperintensity, as opposed to the image on the right representing a masseteric venous malformation. Again, not tumors, malformed venous channels, sluggish flow, not very cellular, very bright T2 signal, and the characteristic presence of phleboliths. No vascular flow voids in these low flow vascular malformations. Another couple of lesions, just to highlight a few additional points. Again, avid contrast enhancement is common with hemangiomas, and these will typically occur in superficial locations much more commonly than in deep locations. So the skin and subcutaneous soft tissues are fair game for hemangiomas, and we can see that this lesion on your left is sitting superficial to the masseter, whereas the venous malformation on your right is actually intramasseteric in location, again, a very common location for venous malformations. And we can see that even though this is a contrast enhanced image, there's only very patchy contrast enhancement within this venous malformation. All right, let's move to our next vascular malformation, the lymphatic malformation. This occurs in two varieties. The much more common macrocystic LM, and these image like cysts. They are going to be well-defined cystic appearing lesions like the images on your right. You can see a very bright T2 cystic appearing lesion. It's actually kind of in a good spot for a second branchial cleft cyst, but notice how it's really soft and it's kind of being deformed by the sternocleidomastoid muscle. It's wrapping around the carotid sheath structures, much softer in appearance than a second branchial cleft cyst. And again, because macrocystic lymphatic malformations will image like cysts, typically there'll be no contrast enhancement or maybe minimally within septations or in the capsule. So in our little scheme, we're going to put this on the bottom right as a non-contrast enhancing lesion that demonstrates very bright T2 signal intensity, basically a common kind of cyst. So the macrocystic forms have been called cystic hygroma. That's a term we want to move away from. The suffix -oma kind of implies tumor, and of course we know these are malformations and not tumors. This location at the root of the neck in the axilla is very common, and you can see this non-enhancing, very T2 hyperintense lesion in a very classic location for a macrocystic lymphatic malformation in a child. The microcystic ones are much more complex in appearance. They, as the name implies, they only have very small cystic spaces, and because there's really not a lot of confluent fluid collections, they typically will not give you that bright T2 cystic appearance, and sometimes they can often appear almost solid. The subcutaneous reticulation that you can see on these images is very classic for the microcystic lymphatic malformation. And the distribution in this patient, the so-called beard distribution, is very common. So you can see how it's kind of wrapping around the lateral face and into the submandibular region. This patient obviously with a large component in the oral cavity as well. Now, the orbit is another great place for lymphatic malformations, and these may be present and small for a very long period of time. Remember, these are soft lesions. The image on the left shows that the optic nerve is actually compressing or sort of distorting the lymphatic malformation, which really means that it's quite soft because the optic nerve is a pretty wimpy structure. But these will often present in very dramatic fashion when there is internal hemorrhage, and internal hemorrhage is very common in lymphatic malformation, so you can imagine how this might present with very acute onset of dramatic proptosis. And if you see fluid levels, hemorrhagic fluid levels in an orbital lesion, it is essentially a lymphatic malformation until proven otherwise, and easy to see on MR, but even on CT you might be able to see those kind of linear fluid levels if you look really carefully. Now, again, there are variants which are composed of components from different vessels. So the lymphovenous malformation, or LVM, gets called venolymphatic malformation, and that's not wrong either. And what this represents is a vascular malformation that has both lymphatic and venous components. So typically there will be both enhancing and non-enhancing components, and most of these will be bright on T2 because both lymphatic and venous malformations will typically be bright on T2. But if you look at this case, you'll notice, first of all, that there is a phlebolith in that enhancing component in the oral cavity. And then there are other areas that are T2 bright that don't enhance, and those are going to be the lymphatic components. So I will often dictate these as there is a vascular malformation that has both enhancing and non-enhancing components. And using the word venolymphatic is fine as long as you are using it because you do see those shared elements and not because you don't really want to think too hard about whether it is venous or lymphatic. All right, our final lesion is the AVM. And here we typically don't see a discrete mass. What characterizes AVMs is the presence of large vessels that sort of permeate the tissues. And what we look for in these cases are the characteristic vascular flow voids on MR. Now, because there is hypervascularity in these tissues, you can get some tissue edema, and that can give you a little bit of enhancement and some moderate T2 hyperintensity. So we're not surprised to see that, but generally these are going to be lesions that we will put into the upper right of our grid as non-enhancing and only mildly T2 hyperintense lesions. So this is an example of an extensive facial AVM. Impossible to draw a circle around a discrete mass. What we're really looking at is the abnormal vessels, and that is what makes up AVMs. So we're going to look for flow voids. We're going to look for large feeding and draining vessels when we are considering the possibility of a facial AVM. Now that was a very dramatic case, but they can be extremely subtle. So this is a child who presented with nasal swelling. And if you look at the T1 and T2 weighted images, you can see that the nose, has kind of lost its subcutaneous fat stripe, and it is a little bit thicker than average. And on the T2 weighted image on the right, there is a little T2 hyperintensity. But the key to the finding is seeing this single vascular flow void, and that's really all that we saw on MR. And this turned out to be a nasal AVM with associated soft tissue swelling and tissue edema. So look for these little flow voids and definitely report them even if you only see one. These are common in and around the oral cavity, and you can see mandibular changes just as a reaction to the hypervascularity, in which case you may see, as in this case, mandibular overgrowth. Compare the left side to the right side, but also the mandible can be permeated with the vascular malformation as well, in which case you can get a whole lot of lytic change, as you can see in this case. So bony overgrowth and lytic destruction can both be the kind of osseous changes that we see in association with arteriovenous malformations. All right, so we're wrapping up. Let's summarize what we have seen for these 4 common vascular lesions. So we, put together our grid with enhancement features on the top and T2 signal on the left, and we saw how hemangiomas, which are cellular neoplasms, give you typically avid contrast enhancement, but only moderate T2 signal intensity because they are so hypercellular in their proliferative phase. We saw how AVMs are really characterized by the presence of their vascular flow voids without discrete mass. They can give you a little bit of enhancement and a little bit of T2 signal intensity on the basis of tissue edema, but really what we're looking for are those vascular flow voids to make that diagnosis. We saw how venous malformations give you very bright T2 signal because they are not very cellular. They're essentially sacs of malformed veins. And because of that, enhancement also tends to be patchy and tends to be dynamic. And also we will see little phleboliths very often within them, and that really can help cement the diagnosis. And finally, lymphatic malformations occur in 2 flavors, much more common macrocystic ones, which image like cysts, as well as less common microcystic lesions that may have a little bit less of that fluid signal because the cysts are so small. We know that lymphatic malformations can hemorrhage, so hemorrhagic fluid levels in a non-enhancing and very bright T2 signal intensity mass should make us think of lymphatic malformations. Also, let's take a second to kind of get rid of the old nomenclature and adopt the new nomenclature as proposed by ISFA. So the old term capillary hemangioma should be abandoned, and these are just all infantile hemangiomas. Lesions that are called port wine stain and strawberry hemangiomas are really just capillary malformations. The old cavernous hemangiomas and ossifying hemangiomas, as we saw earlier, are all venous malformations. And then finally, lymphangiomas and cystic hygromas are more accurately called lymphatic malformations, and we should really try to stick to these terms. Okay, so let's sum up what we've discussed. Well, we mentioned that it's really important to use the right words, and specifically to reserve the term hemangioma for the specific pathologic diagnosis of the common benign vascular tumor of infancy. We talked about how history is important and hemangiomas are not present at birth, whereas vascular malformations, which represent malformed venous channels, are present at birth and will grow somatically with the growth of the child, as opposed to the triphasic growth pattern that we saw in hemangiomas. We saw that you can use the enhancement pattern and the T2 signal to help distinguish the four most common lesions that we see in the head and neck: the hemangioma, venous, lymphatic malformations, and AVMs. But there are some additional imaging clues, such as phlebolyths in VMs, vascular flow voids in AVMs, and hemorrhagic fluid levels in LMs that will help make these diagnoses. So again, be careful with that term hemangioma and keep it for those benign vascular tumors of infancy. Thank you so much for your attention.
Dr. Bieleniuk will now introduce the remainder of our speakers. Thank you.
The next lecture will be given by Dr. Bernadette Koch, Associate Director of Radiology, Cincinnati Children's Hospital, Professor of Radiology and Pediatrics, University of Cincinnati College of Medicine. Her topic is Pediatric Head and Neck Malignancies.
Good afternoon. I would like to thank Dr. Schmalfus and the program committee for inviting me to speak today on the topic of pediatric head and neck malignancies. Our objective for the next 20 minutes will be to review the imaging characteristics of the most common non-ocular, non-thyroidal, and non-salivary gland malignancies that occur in the pediatric head and neck. Many of the lesions that we will discuss occur in multiple locations in the head and neck, including the neck, sinonasal cavity, temporal bone, craniofacial bones, and extraocular orbit. Features that help us arrive at an appropriate differential diagnosis other than imaging features include age of the patient, rapidity of symptom onset, and location. However, as you can see, lymphoma, rhabdomyosarcoma, and metastatic neuroblastoma may occur in many sites in the head and neck. Therefore, location is a less helpful discriminator. Here is a 14-year-old male with a neck mass for several weeks. On CT, there's a dominant right-sided neck mass, mildly compressing the right jugular vein, and other ovoid masses in the right neck and upper mediastinum consistent with adenopathy. FDG PET demonstrates multiple neck and mediastinal nodes. The differential diagnosis with the initial clinical history of a dominant neck mass would have included rhabdomyosarcoma and reactive adenopathy. However, the presence of multiple cervical and mediastinal lymph nodes and several week history of symptoms in the absence of respiratory symptoms makes us most concerned about lymphoproliferative disorders. This patient was subsequently confirmed to have Hodgkin disease. What does lymphoma look like in the head and neck? It primarily presents as cervical adenopathy, but may also involve the sinonasal cavity, skull base, jaw, and extraocular orbit. When presenting as a neck mass, we oftentimes see bulky, non-necrotic adenopathy without surrounding cellulitis and without symptoms of upper respiratory infection that might lead us to diagnose reactive adenopathy. In addition, the number and size of cervical nodes is usually greater in lymphoma than reactive adenopathy. On occasion, lymphoma nodes in the neck, similar to those in the abdomen, may be hypoechoic and hypoenhancing, simulating an abscess. Overall, this is uncommon in immunocompetent patients, but can be seen in up to 50% of immunocompromised patients with post-transplant lymphoproliferative disease. The majority of lymphomas are FDG-avid, and in general, imaging cannot differentiate Hodgkin lymphoma from non-Hodgkin lymphoma, although location and age can give us some idea about one versus the other. Hodgkin lymphoma tends to have two peaks, early adolescence and patients over 50 years of age. Hodgkin lymphoma tends to be nodal, and up to 50% are associated with Epstein-Barr virus. Nodular sclerosing type is the most common, and on light microscopy, all types of Hodgkin lymphoma contain Reed-Sternberg cells. Here we see a teenager with bulky right-sided cervical adenopathy, bilateral lateral retropharyngeal adenopathy, and avidity of the cervical nodes on FDG PET. Of course, the differential diagnosis of cervical adenopathy includes inflammatory disease, which frequently can be diagnosed on the basis of a clinical history. Here we see a patient with streptococcal pharyngitis, multiple cervical lymph nodes, and surrounding cellulitis without evidence of abscess. Cat scratch disease presents with nonspecific adenopathy, as we see in this patient, who has several primarily right-sided cervical nodes several weeks after being bitten in the tongue by a kitten. A key clinical fact in cat scratch disease is that the scratch or bite is frequently forgotten by the patient and family, and the children present 1 to 4 weeks after the inciting event. Mostly in teenagers, but also in younger children, bulky adenopathy, enlarged palatine tonsils, and enlarged adenoid tonsils should raise the question of mononucleosis. Lymphoma can certainly involve any of these structures, but not usually cervical nodes, palatine tonsil, and adenoid tonsils all at the same time. Non-tuberculous mycobacterium may present with cervical involvement, and the key to this diagnosis, shown by Dr. Robeson several years ago now, is the presence of small necrotic areas within the lymph nodes that are involved. In this patient, periparotid and intraparotid in location, and the absence of associated adjacent cellulitis. As opposed to Hodgkin lymphoma, non-Hodgkin lymphoma is most often extranodal in location and more often occurs in children under the age of 15. Non-Hodgkin lymphoma in the head and neck may occur in the sinonasal cavity, orbit, nasopharynx, thyroid, or Waldeyer ring. Multiple subtypes exist. They may be B-cell or T-cell in origin. The most common in children are Burkitt lymphoma and diffuse large B-cell lymphoma. When it presents as extranodal disease, it is typically intermediate in attenuation on CT, iso or hyperintense on T2 weighted images, frequently shows diffusion restriction with or without bone destruction. Here we see a 10-year-old girl with new onset snoring. She has a large right-sided parapharyngeal mass inseparable from the right palatine tonsil, significantly narrowing the oropharyngeal airway. The lesion is mildly hypointense on T2 weighted images, but slightly hyperintense relative to muscle. Shows diffuse enhancement and diffuse diffusion restriction, as well as avid FDG uptake. This proved to be B-cell lymphoma. Differential diagnosis would certainly include rhabdomyosarcoma. Burkitt lymphoma is an aggressive B-cell non-Hodgkin lymphoma that's most common in males. It's the most common form of non-Hodgkin lymphoma in children under the age of 15. Has an incredibly short doubling time and is frequently associated with translocation linked to the deregulated expression of MYC oncogene. Burkitt lymphoma occurs in 3 settings: sporadic, which is rarely associated with EBV; endemic, which is almost always associated with EBV; and associated with immunodeficiencies. Sporadic is most often abdominal. Endemic disease is most often involving that most often involves the head and neck. And endemic disease is most common in Africa and New Guinea. Here we see a 4-year-old boy presenting with orbital apex syndrome secondary to Burkitt lymphoma. We have a moderately enhancing mass involving the ethmoids, extending into the extraconal orbit and the left cavernous sinus with associated bone destruction. MRI demonstrates hypo-intense T2 signal consistent with a cellular tumor, mild contrast enhancement. MRI better demonstrates the cavernous sinus extension, and there's diffusion restriction. Differential diagnosis in this patient with Burkitt lymphoma would certainly include rhabdomyosarcoma and much less likely metastatic neuroblastoma. How about this case? An 11-year-old boy with headaches, right otalgia, 5-pound weight loss, right tongue and chin numbness, and right-sided facial palsy. MRI shows a heterogeneous, moderately hypointense mass in the right posterior nasopharynx. Coronal post-contrast image demonstrates extensive intracranial spread via foramen ovale and extensive destruction of the right sphenoid base. The differential diagnosis would include lymphoma, rhabdomyosarcoma, and nasopharyngeal carcinoma. This patient proved to have parameningeal embryonal rhabdomyosarcoma. Rhabdomyosarcoma is the most common childhood soft tissue sarcoma and involves the head and neck 40% of the time. There are 3 histologic subtypes. Embryonal is the most common, occurs in younger children, and the majority of embryonal rhabdomyosarcomas occur in the head, neck, or GU tract. In these children, it's important to image the entire neck to rule out metastatic adenopathy, and MRI is frequently complementary to assess intracranial extension in children with parameningeal disease if, in fact, the initial imaging modality was a CT scan. Rhabdomyosarcoma is divided by location into orbital disease, parameningeal disease, and all other sites. Parameningeal includes middle ear cavity, sinonasal cavities, nasopharynx, infratemporal fossa, pterygopalatine fossa, and parapharyngeal locations. Here we see a child with parameningeal rhabdomyosarcoma. CT demonstrates extensive skull base erosion, and MRI shows to better advantage the intracranial extension into the middle cranial fossa and the left cavernous sinus. As a primary mass, rhabdomyosarcoma tends to be hypointense on T2 weighted images, heterogeneously enhancing with diffusion restriction, with or without bone destruction, and is frequently hypermetabolic on FDG PET. Although the prior case demonstrated bone destruction, lack of bone destruction does not exclude rhabdomyosarcoma in the head and neck. Here we see a teenager with a mildly hypointense T2 signal intensity mass in the extraconal space of the right orbit. There's mild heterogeneous contrast enhancement and diffusion restriction without bone destruction in a patient with orbital rhabdomyosarcoma. These are 6 different patients with head and neck rhabdomyosarcoma to give you an idea of the extensive variability of the imaging locations, of the imaging characteristics and the locations in the head and neck. Here we see a large heterogeneous lesion in the masticator space with bone destruction involving the pterygoid plates and the posterior maxilla. Another patient with a large heterogeneous right-sided neck mass, significantly compromising the airway. A large heterogeneous mass involving the left nasopharynx and masticator space with associated destruction of the left pterygoids and posterior medial left maxilla. The bottom row shows 3 different patients with nasal lesions. Here we see a lesion involving the left nasal cavity extending post-anteriorly to involve the left nasal ala, widening the nasal inlet without aggressive bone destruction. 2 other patients with primarily nasal ala lesions. one age 4 and one age 10 years. Neither demonstrates bone destruction. These are the scary ones. They appear benign and non-aggressive, but do not let lack of bone destruction sway you away from the diagnosis of rhabdomyosarcoma. Another location for rhabdomyosarcoma in the head and neck is the temporal bone. When occurring in the temporal bone, a key differential diagnosis is Langerhans cell histiocytosis, both of which cause enhancing masses and bone destruction. In general, rhabdomyosarcoma likes the anterior portion of the temporal bone, i.e. the petrous apex and middle ear cavity. Here we see an enhancing mass destroying the petrous apex in a patient with rhabdomyosarcoma. LCH more often involves the mastoid portion of the temporal bone, as we see in this child, with an enhancing mass filling and destroying the right mastoids. Notice it also involves the squamosal portion of the right temporal bone. In addition, LCH is the diagnosis of choice in this patient if you recognize the contralateral squamosal temporal bone mass and the absence of the posterior pituitary bright spot in a patient with diabetes insipidus and Langerhans cell histiocytosis. How about this patient? A 17-year-old with a large nasopharyngeal mass noted on CT during workup of sinusitis. There's a homogeneous mass inseparable from the adenoids and the prevertebral soft tissues extending posteriorly towards the skull base without frank osseous erosion. Differential diagnosis would include lymphoma, rhabdomyosarcoma, and nasopharyngeal carcinoma. That patient had nasopharyngeal carcinoma. Remember, this is primarily an adult disease, accounts for less than 1% of all childhood cancers. Most occur in 40 to 60-year-old patients, but there is a second peak in teenagers. The majority of lesions are non-keratinizing, and the majority of non-keratinizing lesions are associated with EBV infection. In teenagers, the lesions tend to be large at diagnosis, and many have cervical nodal disease at the time of presentation. When metastatic nodes are present, they're frequently large and may be necrotic, as we see in this patient, with a right-sided nasopharyngeal carcinoma who presented many years later with metastatic contralateral necrotic disease. A nice article published several years ago demonstrated the primary imaging characteristics of nasopharyngeal carcinoma in teenagers, including an asymmetric mass, clivus and sphenoid erosion, widening of the petroclival fissure, unilateral or bilateral cervical adenopathy, lateral retropharyngeal adenopathy, and local extension into adjacent spaces. In addition, mastoid opacification is common, secondary to eustachian tube dysfunction, and ipsilateral internal carotid artery narrowing and pterygoid sclerosis, in our experience, are quite common. Here we see a left-sided nasopharyngeal mass with an associated large lateral retropharyngeal lymph node and invasion of the prevertebral musculature. There's also associated fluid in the mastoids secondary to eustachian tube obstruction. Here's another patient with a right-sided nasopharyngeal carcinoma, moderately enhancing mass, invading the prevertebral musculature. There's extension towards the carotid sheath with the vessels deviated posterior lateral. There's ipsilateral internal carotid artery narrowing, large, bulky ipsilateral cervical lymph nodes, sclerosis of the right pterygoid base, and invasion of the floor of the right sphenoid sinus. Another malignancy that may have cervical adenopathy at initial diagnosis is metastatic neuroblastoma. Neuroblastoma is the most common malignancy in children under 1 year of age, and the majority arise in the adrenal gland or retroperitoneal region. When cervical disease is present, it's almost always metastatic, involving cervical nodes. There's nothing specific imaging-wise. Here we see two different patients with left-sided cervical adenopathy, one with heterogeneous enhancement within the lymph nodes, and one with frank necrosis simulating a cystic lesion. Less than 5% of neuroblastoma arise in the cervical region. These patients present with feeding difficulties, palpable mass or airway symptoms, and when they occur, they're in the posterior aspect of the carotid sheath. They deviate the vessels anteriorly, as we see in both of these patients. They may splay the carotid artery and jugular vein. Cervical primary neuroblastomas rarely calcify, unlike the adrenal origin lesions, which frequently calcify, and they rarely extend into the spinal canal. In addition to cervical metastatic adenopathy, other head and neck locations with propensity for metastatic disease in neuroblastoma include the calvarium, the skull base, and the craniofacial bones. When they occur in these locations, metastases almost always demonstrate aggressive periosteal reaction associated with enhancing soft tissue mass, as we see in this patient with a frontal bone metastasis. Another patient with aggressive sunburst type periosteal reaction and a large soft tissue mass, and a patient with a mandibular metastases. And when the metastases occur in the bilateral skull base, the children may present with raccoon eyes. Here we see a 7-month-old who presented with elevated urine catecholamines and raccoon eyes. Post-contrast fat-saturated MR image demonstrates bilateral metastatic disease to the pterygoid, or to the greater wing of the sphenoids and the lateral orbits, as well as the right squamosal temporal bone. Another 7-month-old demonstrates bilateral soft tissue masses with aggressive sunburst type periosteal reaction involving the greater wing of the sphenoids and lateral orbits, in a patient with typical aggressive periosteal reaction of neuroblastoma metastases. Lastly, nothing terribly specific about any of these, but just remember that malignancies other than neuroblastoma and nasopharyngeal carcinoma may metastasize to the cervical nodes in children, just as they can in adults. We have 2 patients on the left with papillary carcinoma of the thyroid presenting with neck masses that represented metastatic disease, a young child with hepatoblastoma and a large necrotic left anterior neck metastasis, and a teenager with testicular carcinoma presenting with a supraclavicular metastasis. Our take-home points: remember that Burkitt lymphoma is an aggressive non-Hodgkin lymphoma associated with EBV and typically demonstrates significant diffusion restriction. Rhabdomyosarcoma on imaging may be indistinguishable from lymphoma. However, remember it has a rapid turnover time, frequently destroys the skull base, but at other sites in the head and neck, such as with orbital and nasal lesions, it may lack bone destruction. Nasopharyngeal carcinoma in teenagers, think of this when you see asymmetric adenoid tissue. Look for associated adenopathy and skull base erosion to help arrive at the appropriate diagnosis. Neuroblastoma in the head and neck is most often metastatic cervical adenopathy or metastases to the skull base, craniofacial bones, or calvarium, and all of these typically show aggressive sunburst periosteal reaction. Primary cervical neuroblastoma is rare, but should be thought of when a solid mass is noted in the posterior carotid sheath in a young child. And don't forget, similar to adults, other primary malignancies may metastasize to cervical lymph nodes in children. Thank you for your attention, and thank you for participating in this unprecedented virtual national meeting.